So I think we've got enough people now. So I'm going to start. So if I could just ask all panelists to go on mute, please. Thank you. So Assalamu alaikum, everyone. My name is Akila Ahmed and I'm the founder of She Speaks, We Hear. So for those of you that don't know, She Speaks, We Hear is a platform dedicated to elevating the voices of women from everyday and marginalized backgrounds and to reflect their everyday lives and perspectives. So we have organized this seminar today because we've had a lot of feedback from our own sort of networks and our own families actually, that there's a lot of confusion and misinformation and also quite a bit of hesitancy around people taking the vaccine and what it will mean for us as women, and I think especially what it will mean for Black and Asian and women from those groups, but also women from ethnic minority communities. And there's also some stats as well which show that there's quite a bit of hesitancy around the vaccine. So we thought it would be really good to bring together panelists who are experts in their own different fields, and we'll introduce them in a bit as we hear from them, to talk about their perspectives on the vaccine, but also to allow space for questions. So some of you have already sent in some questions, which have been fantastic. I'm hoping that we have the time to go through all of them. Hopefully we will. And then you also have an opportunity to ask questions. You know, either you can put them in the Q&A during the seminar, or you can wait till the end when we open up for questions and answers. Please do introduce yourselves on the chat so that we can know who's here. And if you do want to kind of raise your hand, I can see somebody has already raised their hand. You know, feel free to do that. And I'm going to check in a moment why some people have raised their hand just to find out what's going on. Okay, so without further ado, I'm going to hand over to my colleague Alia Zaidi, who is the head content and a marketing expert for She Speaks, We Hear. And she is going to give us a short sort of presentation just to kind of set the scene for the webinar, and then she will introduce our speakers. So over to you, Alia.
Thanks, Akila. So I'm just going to attempt to share my screen. Let's see if it works. Okay, and I'm going to play this. So Akila's always kind of already given us an overview of hopefully you can all see that. So she's always going to kind of given us an overview of She Speaks, We Hear, but just kind of to reiterate, She Speaks, We Hear originally started as a blog, but I think since lockdown we've started a series of Instagram lives, and we've kind of started with the aim of kind of giving women a voice, and we've taken that kind of more literally and moved from a lot of blogs and things like that to kind of online content, video content, and as part of that also a series of seminars. So just to set the scene, I've got some stats about BME British adults, and these basic stats basically show that even though there's statistics to show that BAME adults are more likely to die from the vaccine from COVID due to a variety of reasons, there's also additional research that suggests that ethnic minority groups are statistically less likely to take up the jab. And there's obviously various reasons for that, and that's something we can ask the panel. The one thing we don't know is how much of the vaccine is actually being wasted. That's government information which we don't have access to. And we don't know why it's being wasted, but there might be a multitude of factors, but at least one of those factors could be rooted in just adults refusing to take up the jab. And, you know, it's understandable why there might be so much reluctance around that. It's kind of COVID isn't very new, it's so many uncertainties. But if we look at kind of some of the headlines of why BAME groups are less likely to take up the vaccine, here are just a handful of headlines which suggest that certain groups are more likely to kind of reject to taking up the jab. So what's the reason for that? Well, there's one of the major reasons is kind of, well, there's an anti-vax movement which has been gaining ground, and they're using kind of COVID-19 vaccine to capitalize on their agenda. But also, it's kind of understandable that people would have a lot of questions about a new vaccine, something that's just emerging, and so much has happened in very little amount of time. But also the rise of social media is definitely a factor as well. So messaging on WhatsApp, social media, Facebook, it makes it really hard for everyone to kind of assess what is real, what is not. I think all of us have at one point fallen for fake news. I know I have. And it's really hard to kind of actually find out what we're being told is actually true or not. And who amongst us hasn't fallen for fake news, accepted what a message is telling us, and then Googled it and then realized, well, actually it's fake news. It's happened to me loads of times, and I'm sure it's happened to everyone who's probably attended this. It's a common problem. And so therefore, it's even more so when this kind of in the case of the vaccination. So in response to that, we set up this event. Why do we set up this event? Well, to address some of the most common myths, to give people access to a panel of experts so that you can ask them all of the questions that you have, and to inform and educate, and to help you make an informed decision, because all of us could do with more information. So that's why we set up this event. And I'm just going to stop sharing now. And so the first person on our panel, I want to introduce Dr. Muna Abdel Aziz. Dr. Muna is the Director of Public Health for Salford. She was previously the Director of Public Health in Warrington, and from the 1st of January, she is the Director of Public Health. She's been leading the public health response to COVID-19, advising care homes, schools, colleges, nurses, and workplaces. She set up the local test and trace team in Salford, who are acting early on suspected cases, arranging testing, tracing their contacts, and managing outbreaks. Her motto for this is keeping the virus visible so we can stop onward transmission, and every small change can make a huge difference. So without further ado, I would like to hand over to Dr. Muna. Thank you.
Thank you very much. I'm really pleased to be speaking to you today, and I'll just introduce some of the main points about the virus, what we know about it, and what we can do to stop the spread, and how we manage outbreaks. Where does the vaccine come in? Why vaccine hesitancy is the new Black Lives Matter, and what you can do as the audience. So I'll just go through some of my slides. I'll just do it in this way. So just introducing the virus, and this is a very familiar image. However, of course, this is an artist's depiction, because the virus is so small. It's 300,000 times smaller than a pinhead, and you can't see it with other than through an electron microscope. But this image is we understand, demonstrates the spikes that a coronavirus, the kind of crown that's around the virus. But if you were to break it open, you'd see within there the actual RNA, which is the nucleic acids that make up the virus, and surrounded with a lipid layer. The lipid layer is very important because that's how we wash it off and how we kill the virus, just using hand hygiene and alcohol gels. The other point to realize is that when we do undertake tests to find the virus, there are a range of tests that are being undertaken. The most well-known and standard, the one that we have been testing right through, is what's called the PCR, which amplifies the virus RNA.
Dr. Muna, I'm so sorry to interrupt you, but your slides, I don't know which slide you think you're on at the moment, but your slides are not moving, just to let you know.
And that is a very good point, thank you. So I'll just hope that this works for us now. So I'm hoping that this is visible to you.
It's visible, but oh yes, now we can see the second slide. I don't know if you will have to manually sort of move it every time you want to click. I mean, every time you want to go to the next slide.
Yeah, I'm hoping it will work. So so yes, the familiar artist depiction. So thanks for interrupting, because it's familiar. It shows the cross section of a virus, with the RNA right in the middle, and it's surrounded by a lipid layer, which you can wash off or you can damage using alcohol, and that's how the virus is killed in the famous hands-face space. So it's the hands element of that. But also this slide shows some of the tests that are undertaken to detect the virus. And the most familiar one is the one that you send to a lab, which is the PCR one, which detects the RNA itself. And you can amplify the RNA. So sometimes you can continue to test positive, even though you're no longer infectious, just because you have some very low level of that virus RNA, and which is amplified, and it still continues to be detected for many weeks after you've actually recovered. And then you can see this red red zone where you have week 1 and week 2 from around the onset of symptoms, where you're shedding the virus at the maximum point of time. And that's where the rapid tests can detect the virus and that you're actually infectious when you run this rapid testing, and it picks up the antigen. So that's why it's called a rapid antigen test. And sometimes it's called lateral flow device tests. So these are the rapid tests where you get the result within the hour. And if you come positive on that rapid antigen test, you are highly likely to be very, very infectious. And that's why we we advise people to actually isolate at home, particularly following that rapid test. And then you'll see the antibody response starts to kick in after the second week, and you are able to fight off the virus. So the PCR sometimes isn't able to detect the virus because you've mounted an antibody response. And antibodies are formed to fight off the virus, and they remember the virus, but they're also the first line of defense before some killer cells start to come in, and you're really immune at that point in time. However, with this virus, we don't know how long immunity lasts, and that's something that we will have to live through and find out as we go along. I just wanted to sort of demonstrate here with this slide, and it's very small, but perhaps it just highlights the point that different areas are at different stages of their outbreaks. And these are different areas across the world, but also different areas within the UK. So just using the example of England and Salford, you can see that the colouring is very different. So where you have...
Simona, I think it hasn't moved again, the slide. I'm so sorry to keep interrupting you.
This is very, very, very tricky. So I'm just wondering if I could unshare and start again.
Okay, sure, go ahead.
So is this moving?
Yeah, that's moving.
Right, sorry about that. So there are a number of colors on these slides. So whether you have the dark blue color, and this is for looking at different age ranges, this data is available on the government website, so it's readily available. Where you have the dark blue color, that's where you have very intense transmission. And you can see right at the moment in the UK, there is intense transmission across all ages. But when you compare a smaller area like Salford, where I cover, you can see that it's a little bit more patchy and much more localized to particular ages. It's much more localized to particular communities. And we've seen the virus sort of really move on from the older people to the younger people and back to older people again. And we have seen sort of the virus go sort of transmission become really intense in particular communities like the Black and Asian ethnic minority communities. So there are the 5 alert levels, of which we're in the highest now in the UK, where you stay at home unless you've got some really prescribed reasons why you can leave the home. But also just wanting people to remember that to stop the spread, you also need to stay at home if you're feeling unwell, and that you should get a test. And if you are symptomatic, get the PCR test, the one that goes to the lab. Don't depend on a rapid test. Because sometimes that will be, it may miss some of the cases because you're not in that window where we saw a few days before or a few days after the symptoms have started. Hands, face, space, that's the standard, but that will only stop the virus from getting to you or from you taking it on, moving it on to someone else. The best way to stop transmission is for people who are carrying the virus to stay at home. We've recently got the vaccine now, and at the moment we have 9 out of 10 of every of people who are older than 80 years old, and over half people in their 70s have now been protected by the vaccine. It's the first dose of the vaccine that they've been protected with. Now that stops them getting the severe consequences, but it doesn't stop them getting infected, and it doesn't stop them passing it on. So remember, we are preserving life and we're making history. So if you look at the history of vaccination, you can see that it's because of vaccines that the mortality rate decreased very much in the last century. And the death rate in this graph shows that when we had the influenza pandemic in 1918, you immediately saw that massive surge of deaths due to influenza. Well, now we're seeing a similar surge now of deaths due to coronavirus. But vaccines do save lives, and over the years, there have been many vaccines that have been manufactured and are now in use. And so it's not new that we develop vaccines for all of these different bacteria or viruses. And the COVID vaccine, therefore, has built on that well-known, tried and tested technologies to make sure that we get the vaccine in time. So just wanted to point out on the Black Lives Matter point I raised earlier. You know that the vaccine visited our communities first, and we are seeing that it's not leaving our communities. It's probably going to leave our communities last. And there are many reasons for that. Some of it is because of exposure. You know, people are exposed to the virus as part of their work or having to go out to work. Care workers, NHS workers, frontline staff from BAME communities have been most exposed. But also we know that they're more likely to get the more severe consequences and sadly the deaths. And the vaccine is the light at the end of the tunnel. The vaccine we're very fortunate to have here in the UK, where we have a vaccine supply. It has been arranged, there are deals in place. But if you compare that with other countries, some other countries where the WHO has to support the so-called COVAX countries will not get this vaccine until 2024. So if we are offered the vaccine, we must remember that we're very fortunate to have that and that we should take it up. Well, the more recent survey that I know that was just mentioned, looking at attitudes towards the vaccine, it's very different across ethnic minority groups, where 85% of people from a white background said that they would take up the vaccine when it's offered. But overall, 69% of people from an ethnic background said they would take it, compared to only 49% of people of Black heritage. The largest proportion of reasons given were fear of side effects or the long-term effects or safety concerns. And 45% of people who were unlikely to take up the vaccine said, well, they prefer to wait to find out more. There'll always be some people who will not take a vaccine. We've seen that vaccine anti-vax for all the other vaccines. That's about 10% of people. So really this talk is aimed at the people who said that they would prefer to wait, that 45%, because we really want to urge you to take it up. This vaccine is being offered to people who are most likely to benefit and those who we really, really want to protect. So when we vaccinate our frontline workers, we want the Black and Asian minority ethnic backgrounds who are most exposed to take it up. And when we vaccinate patients with health conditions, and we know many of our communities have diabetes or heart disease or any of the other health conditions, and those who are elderly, our elders, we want to protect them. And that includes people of a BAME background. So whoever's offered a vaccine should take it up. And remember, don't wait to be re-invited, because it will take many weeks before someone sort of re-invites you. By that time, it may be too late. It may be too late for you or for your loved ones. And so just really wanted to urge people to take up the vaccine. And then my colleagues, the other speakers and panelists will be able to tell us more about why and how. Thank you.
Thank you, Dr. Muna. That was really, really enlightening. I think all of us are kind of bombarded by so many messages and so much in the news that really kind of clarified a lot of those points. So our next speaker is Dr. Sara Saigol. Dr. Sara Saigol, she's a general medical practitioner. She's also a youth leader. She's been involved with various organisations in a voluntary capacity, including young Muslims, and she's worked with the Islamic Society of Britain for almost 3 decades. So Dr. Sara, over to you.
Thank you very much. Thank you. Hello, everyone. Assalamu alaikum. Thank you so much, Dr. Mona, for a fascinating presentation. Are you okay to share my slides, please, Akila? So I'm a GP, and I would like to start by just talking about how difficult a time it's been, you know, nationally, internationally, physically, emotionally, spiritually, mentally. It's been a really difficult time. We have gone past the 100,000 losses in this country. We are facing 9,000 global deaths a day, and it's been worked out to be 3 deaths a minute. So it's a huge, huge catastrophe that we're going through with this pandemic. And I know so many people have lost loved ones, and when I go onto my social media, I can see that it's very, very palpable. And then apart from the, you know, physical loss of people and loved ones, we have the economic consequences as well. As GPs, we're seeing the mental health consequences. We're seeing people alienated and isolated. And it's very hard sometimes when you're on the phone with a very elderly, vulnerable patient who needs to be seen, but is too scared to come in to see you. You can just measure the difficulty by that. So I did want to just say a few things about general practice just to start with. There's this idea in some pockets of the country that general practice is closed. We're not closed, we're open. We've been open right since the beginning. Whoever needs to be seen will be seen. We're being very innovative in seeing patients, so we can see photos, we can do video consultations, we can do telephone consultations, but if you need to be seen, you will get called in. You must get yourself seen. Don't feel that because we're in a COVID pandemic that other things aren't important. They are. Mental health is important. Contraception in lockdown is important. Children's health is important. So please contact your doctor. Just yesterday, an old friend of mine was on the news locally, and she was recorded giving the vaccine. We've hit 10 million vaccines with frontline staff, and it's absolutely amazing the effort that's gone into rolling out the vaccine. It was wonderful to see her being interviewed as well. So frontline workers are at the front line of giving the vaccine. As soon as I got my call, I got there. It was snowing and I got stuck on the way there, but I made sure I got my vaccine. It was a drive-through vaccine. So I literally stayed in my car and the nurses and doctors were going around vaccinating. They were in the snow, but because her hands were so cold, I felt nothing. I actually felt nothing. I worried that maybe I hadn't even received the vaccination. And just a few other points, just as an introduction. If you have relatives who have complex conditions like asthma and bronchitis, chest conditions, heart conditions, it might be worth investing in a few things like an oxygen saturation monitor, which goes on a finger, not a smartphone app. It's a really good thing to have in the house that you can tell your GP what kind of oxygen levels someone who's got a chronic condition has. Hands must be warm when you use it. And a blood pressure monitor. It's really good to have just a few things for really complex people in the house. But I'm going to carry on. That was just a little bit of introduction to general practice. And by the way, my father is an over 75-year-old single-handed GP. And it was really important to us that he got vaccinated, and he got it as soon as he got the call. So we're really pleased he's had his part 1 at least. So COVID-19, the coronaviruses are a large family of viruses. They can affect you just with the common cold, the MERS virus, the SARS virus, were all coronaviruses, which is one of the reasons why the vaccines come out so quickly. It's one of the things that people are worried about is why has it come out quickly? Well, the technology of dealing with coronavirus was there, and it's just been accelerated now. We know the coronavirus first emerged in Wuhan, China, late 2019. First 2 cases in the UK were 2020. And in March 2020, the WHO declared COVID-19 as a pandemic. As I said, we've lost 100,000 now lives in the UK. For those that say, well, look, it's just like the flu, it's no different from the flu. Well, actually it is, because it kills 10 times more than the flu, number one. And number two, what's great about our vaccine is it's far more effective than the flu vaccine. The flu vaccine has about 60% efficacy. COVID vaccines are looking at more than 90%, but we're going to get into the vaccine. What's really sad now is lately we're seeing younger and younger patients going into hospital being very ill. So 18 to 64-year-olds are now making up 40% of COVID admissions. So let's not underestimate the harm that this virus can cause. So as Dr. Mona said, it can spread respiratory. So we're talking about breathing, sneezing, coughing, and just talking can spread coronavirus by respiratory particles, as well as direct contact. So the virus can stay on cardboard, plastics, and stay in the steel for days. Now, this is really important, and I know Dr. Mona touched on this, is the asymptomatic or pre-symptomatic spread. So the fact that you can have the virus and you can be well and not know you're going to become unwell, and that's when it's often spreading. So it's 3 days, up to 3 days before you start to feel unwell, that you can be spreading coronavirus, and 40 to 50% of cases are thought to be from asymptomatic spread. Most people, if they get coronavirus, will be unwell at around 11 days. Now, this was a consultant who was, a consultant involved in the vaccine production who was saying that there was a wedding. One person went to a wedding. There were 50 people at the wedding, yet 7 people who weren't at the wedding died as a consequence of the wedding. I know it sounds like a riddle, but somebody somewhere was asymptomatically carrying the virus. Somebody caught it at the wedding and took it back to some vulnerable people. 7 people died. So our actions have consequences that we can't even predict or imagine. In terms of clinical symptoms, most people, 81%, will just suffer a mild to moderate disease. 14% will be severely unwell, and 5% will be critically unwell. So let's look at the symptoms. I'm sure we're all aware it's one or more of the following that would alert you to, could this be coronavirus? A new continuous cough, a high temperature, and a change or loss in the sense of smell or taste. We are, however, seeing stomach, gastrointestinal symptoms in children, so nausea, diarrhea, vomiting. We're seeing skin rashes, and there's something called COVID toes, sore throats, and malaise, so really feeling tired, and myalgia, muscle ache. Can we go on to the next one? Thank you. So what are the risk factors that you may, so we said majority will be mild. What are the risk factors that you may suffer it more seriously? So it's the age, older age group, those with chronic, long-standing, difficult conditions like chronic bronchitis, cardiovascular diseases like heart failure, diabetes, and you'll see that so many of these affect the BAME communities: obesity, sickle cell disease, kidney disease, and being immunocompromised from transplantations or from cancer, as well as those that are more likely to suffer are those who are frontline key workers and the BAME community. So here you see 3 times, the BAME community is 3 times more likely to contract coronavirus and 5 times more likely to have a serious outcome than the white community. And what is the reason? Well, Dr. Mona spoke about that, and there's the intersection with poverty, there's the intersection with chronic premorbid conditions, so other medical problems. Institutional racism has been spoken about, key workers and frontline workers. Children, it is thought, there's not that much data, but it's thought that less than 5% of cases will be children. They suffer in a much milder way. They may be unusual presenters, so more with stomachache and diarrhea and vomiting, but they're unlikely to be key drivers in the transmission, is the thought at the moment, but there's more data unraveling there. Next slide, please. Okay, so the vaccination. So I said that, you know, I went to get mine, and I'm so glad my dad went to get his. I've got friends who have been involved in the vaccination process. You know, they would go and they'd do it unpaid if they had to, just to try and get a grip on this pandemic. It felt to me the day that I got my number 1 done, I've not had my number 2. It's been 4 weeks, it's been delayed, but I felt like there might be a light now. There might be a rainbow at the end of this very dark time. So what are the side effects of the vaccination? Well, in the main, they're mild to moderate, and the data is that within 2-3 days and up to 5 days, those symptoms will go. So mainly pain in the injection site, fatigue, so exhaustion, maybe a headache in over 50%, fever, myalgia, which is muscle ache, chills, and arthralgia, which is joint aches. Lymphadenopathy, so less than 1% may have an enlarged lymph node, and we have heard, you know, colleagues of mine have said just had a big lymph gland, but then that goes within a few days, and a mild fever. So just be aware that those are the side effects of the vaccination. And those who are in the trials, there's been no serious critical side effects of the vaccination reported so far, yet we know that there are 3 people dying every minute of COVID. So I think it's really important to balance risks and benefits. The next slide, please. So long COVID, it is now thought, and there's emerging data on this, that 1 in 10 people will suffer from long COVID. Long COVID is an exaggerated immune response to the virus. So if someone is unwell from COVID for 4 weeks, 6 weeks, 8 weeks, different papers say different amounts of time, are still unwell, consider long COVID. And one of the markers of long COVID is that it's relapsing and remitting. So people say, look, I feel really good today. And the next day, I feel like I've been hit by a bus, you know. One day I can go out for a run, and one day I just can't get out of bed. So it's this profound fatigue, brain fog, cough, heaviness on the chest, shortness of breath, palpitations. We're seeing a lot of neurological pins and needles, numbness. So these unexplained symptoms, fever. So what's really important in the papers now is to pace yourself, to learn your patterns, to know the time of day when you can actually get up and do the things you need to do. Pace yourself, don't overdo it. Stretching is really important. Long COVID is more common in women, by the way, twice as likely. And then if you do start exercising, then leave it till 2 to 3 weeks after symptoms resolve, and aim at only 60% of your maximum heart rate. There are now long COVID clinics. And I'm sure that we'll be discovering more and more about long COVID. I think that's data that's emerging. And vitamin D, because a lot of our audience may be from the BAME community, just be aware, we are going to be producing less vitamin D from sunlight. We're not in a country which has a lot of sunlight, but also our skin will not be producing as much. So the data for those of color is to get yourselves a baseline vitamin D tablet, you know, on your kitchen table and take it every day. You're looking at 400 international units. I take 800 international units, and everyone really between the months of October to March should be taking vitamin D, because we just haven't got enough sunlight. There isn't data to prove vitamin D deficiency, but medical professionals really are saying, look, what's going on here? There's so much of the BAME community just being wiped out by this pandemic. Let's just take vitamin D. What's the harm? So don't overdo it. 800 international units a day, 400's in the papers, and 800 would be around what's in a lot of the documents. And is that my last slide? So if I could just go back to the first one, Akila, if you don't mind. Oh, it's okay. It's okay. I know the point that I just wanted to finish by saying your GPs are there. They want you to contact them if you're unwell. They want you to be in touch. They don't want you to be scared at home, not getting in touch. It is mainly telephone consultations. If the doctor needs to see you or you need to see the doctor, they will call you in. We are not closed. We are seeing patients all the time, but we need to be seeing the people that really need to be seen first. So please get in touch with your doctor and do consider whichever vaccine is available as soon as you're called. Thank you.
Thank you, Dr. Sara. That was really good. And I really like especially the reassurance about going to see your GP. Our next speaker is Dr. Kiran Rahim. Dr. Kiran is a paediatric doctor. She's working on the COVID response with the British Islamic Medical Association. She's also on social media as the Munching Medic. She's been using social media for health promotion and especially raising awareness about COVID. And she's been redeployed in intensive care. So she's seen the first-hand effects that COVID has had on BAME communities. So over to you, Dr. Kiran.
Assalamu alaikum and hello everyone. Thank you for giving up your Thursday evening to join us. To just reiterate and echo what's already been said by everyone on this panel is that, you know, COVID is real. I know there's a lot of misinformation, a lot of fake news surrounding it, but as someone who doesn't even work with adults and having to have been redeployed to a situation where people were dying, the only way I can describe it is as like flies, one after the other, has really brought home the reality of how disproportionately Black and ethnic minorities are affected. So just to give you an idea, we know in the first wave, and this is data that's also been released by Public Health England, we know that in the first wave, if you were from a Black background, you were 2.5 to 3 times more likely to die from COVID or get very, very sick than your white counterparts. And we know Asians were almost two times more likely to die. Now, we are seeing a similar pattern in this second wave, but what we're actually seeing is that the Asian population is more likely to be adversely affected, slightly more marginally than the Black. So we know that in the north and the east parts of London, where most of our Asian communities reside, we are seeing higher numbers. And we also know that the Asian population only makes up for about 20% of London's population, but actually they make up about a quarter of our cases. So I think just to hammer that point home, that we don't know why Asian and Black minorities are so adversely affected, but we do know that it's a complex interplay of things like social deprivation. We are more likely to have comorbidities. We are also more likely to be vitamin D deficient, which has a really important role in supporting and maintaining your immune system. And I think we are unfortunately also, as research suggests, more likely to believe in conspiracy theories. Now, the reason for that is historic. So, in the UK, there has been, over the number of years, a systematic distrust in organisations from people in Black and ethnic minorities. That's due to, not being represented at top levels. That's been due to poorer health outcomes generally. So, for example, our women are more likely to suffer in things like labour. Our babies are more likely to die. So there is a historic case about why we don't believe in science when it's presented to us. Now, the thing that I'm going to talk about today is the vaccine myths that have been going around. So I'm part of the health promotion team at the British Islamic Medical Association. And actually our work in the last year has grossly been centered around vaccines, around COVID, and educating particularly the Muslim community, but not exclusively, about how to cope with the vaccine. I am going to put a little link in there in the chat box for you guys to check out all of our publications. I think it's really, really important for you to have a read, but to just go through some of the myths that we have heard in the community. So the first one is that the vaccines contain animal products that are going to harm you. There's no evidence of the vaccines containing animal products. I think the one vaccine that has a chimpanzee adenovirus, which is the AstraZeneca, is a virus that's been modified, but that doesn't mean that we're putting animal products to you. Like Dr. Shagufta Ahmed said, these vaccines go through rigorous steps before they are, allowed to be put into human consumption. The second thing I want to talk about is that for the Muslim community, that the vaccines are haram. So haram is what it means is that it's forbidden. I don't know if our audience is largely Muslim, so I'm just explaining it. So the things that we've heard is that they contain alcohol, they contain pork, and they contain genetically modified organisms. So there is no evidence in any of the vaccines that there is animal product, particularly pork, and you can see the details on our website. BIMA has worked closely with a lot of Islamic scholars, including the British Board of Scholars and Imams. We have worked with, doctors in the field. We have worked with public health experts, we have worked with immunology experts, virology experts to produce our guidance. And none of it shows that there is any alcohol, any animal product or GMOs in the vaccine. The AstraZeneca vaccine has a small amount of ethanol, and this is an amount that is found less than the amount that's found in bread. The bread that we eat every day, it's less than that. So unless you are not eating bread for religious reasons, there is no religious reason for you not to get your vaccine. Okay. The other myths that we've heard about on this sort of with the COVID is that it causes you to be infertile. I think that's a really, really important myth to consider, because we know that women are also, likely to not get the vaccination because of it. There is absolutely no evidence that it causes infertility. In fact, several people have since become pregnant and have had babies after they have received their vaccines, both in the trial phase, and we now know that people that have been vaccinated, both healthcare professionals and the public, are now pregnant. And you know, the updated guidance from the Royal College of Obstetrics and Gynecology, so they are the experts in the field, is that you can have the vaccine if you're trying to conceive, if you're pregnant and you fall in a high risk group, and if you're breastfeeding. But you should take these and you should have a discussion with your GP or your specialist doctor that knows your health if you are concerned. The other thing I want to talk about, and now this has come up a lot, so my background is that I'm a paediatrician, so my expertise is in children right from the age of when they're born to when they're 18. Now, a lot of people argue that pregnant women and children weren't included in the trials, and so therefore the vaccines are not safe. This is normal, okay? It's considered unethical to include pregnant women and children in trials. Children, because they can't consent, so they usually can't consent to what's happening. They don't usually have the knowledge to understand the vaccine process and you know how it's going to affect them, but also it's just not morally right. Pregnant women, for that reason as well, when you're trialing something, it's considered immoral to trial something on women that are carrying a baby, because we don't know what the effects of that medication that you're trying. So this is normal practice. It is normal practice to not include children and pregnant women in trials. That doesn't mean that we don't give vaccines to pregnant women. So just to reiterate that point home, we give every year, we advise pregnant women to get the flu vaccine and to get the whooping cough vaccine, because we know that the mum passes on immunity to the baby, which is important once the baby's born. Now, the other thing, one of the other myths that I wanted to talk about, let me remember, I've just got my slides up. Yes, is that the vaccine is going to modify your DNA. Now, Dr. Muna did a really lovely talk about where the DNA is. So just to talk about DNA, so the DNA is genetic material that tells our body who we are. So it's responsible for all the things that go inside of us, but also things that you can see on the outside. So our phenotype and our genotype. The DNA is very, very safely guarded inside the nucleus of all of our cells. Okay. Now, I know there was a lot of concern regarding the Pfizer BioNTech vaccine because it's new mRNA technology. There is absolutely no way that the mRNA is going to alter anyone's DNA. It just doesn't go into the nucleus of the cell. Once it enters the cell, it triggers the protein that we're using, the spike protein, it triggers the immune response. And then once that response is triggered, the RNA is completely broken down pretty much as soon as it enters the body. So there's no reason to believe that this has been designed to harm us. Great. So the other things, I mean, I know we're running a bit behind schedule and we've got lots of things to talk about, but the final thing I want to talk about the vaccine is the new COVID strains. So a lot of people are saying that there's no point in vaccination because we have several new strains of the coronavirus. There's absolutely no evidence to suggest that the new strains are going to make the vaccine ineffective. We know that viruses mutate. It's something that they do. So the flu virus, for example, mutates every year. Sometimes it mutates several times in the year. But we know that the vaccines, that all three of them that we have, are targeting that spike protein, which is expressed in all of the strains. So please, if you are offered the vaccine, go and get it. Now, the one thing that I'm always asked is if I've had the vaccine. I have. If my parents were eligible for it, I would be dragging them down to get it because that's how pro-vaccination I am. If my children were eligible for it, they're not. And this is another common thing people are worried about. So children aren't currently allowed to get the vaccine under 16. So 16 and over, we'll talk about later in the questions. Now, the other thing I wanted to just briefly talk about is the coronavirus spread at the moment. So we know from the first wave that there was a massive surge in cases, and about a month, so 4 to 6 weeks later, we saw several sick kids. So they had something called pediatric inflammatory multisystem. So it's called PIMS-TS, and this is where children get really, really sick. Even though we know they're not as severely affected, we know from last the last wave, that we had about 200 kids that got really sick, ended up in intensive care, and unfortunately we had a few of them pass away. We are expecting that same surge in a few weeks' time. Now, the difference is that COVID is so much more worse than it was last time. So we're expecting that surge. So if you're watching and you can get the vaccine and you can protect the vulnerable people around you, please do. And the other thing I want to just quickly home is that, remember the purpose of the vaccine. The vaccine is a small part of a larger solution. Okay, so the vaccine does not stop you from getting coronavirus. And I want to make that really clear, because a lot of people are saying that, you know, the vaccine has failed. The purpose of the vaccine is not to stop spread. The purpose of the vaccine is to stop you becoming very, very unwell with it. Okay, what that means is that once your body, so one of the reasons that people get very, very sick with COVID is because there's a massive inflammatory response. Now, an inflammatory response is when the body's immune system goes into hyperdrive and it starts attacking often healthy tissue. We know that COVID mainly affects the lungs. So when that happens, we get something called fibrosis, which is essentially the lung tissue dying. And once you get fibrosis, you can't repair it, which is why we also have long COVID, because we know people that get COVID and recover, their lung tissue is not the same. And we know that from chest x-rays and CT scans, like 3 to 6 months down the line. So remember, the purpose of the vaccine is to stop that fibrosis process, so that when you do get coronavirus, you don't become as sick, and your risk of dying and your risk of having long COVID is reduced. To stop spread, you still need to wear a mask. You still need to wash your hands and practice respiratory hygiene, and you still need to maintain social distances. And by and large, you still need to follow the guidelines for all of us, because I promise you, if we don't, we are still going to be in this situation 6 months from now, a year from now, 18 months from now, because the vaccine is not there to stop coronavirus spread. That's it. I'm going to stop talking now.
Thank you so much, Kiran. That was really, really helpful. Loads of questions have been coming through on the Q&A and also on the chat. And we also received some questions before the seminar started. So I'm just going to sort of crack on to asking some of those questions. So basically, I think we can kind of group some of the questions together. So there's been lots of questions about, you know, there's 3 different types of vaccines, which one is safe, which one can we take. There's going to be, you know, stuff about mixing vaccines now. So I was wondering if I could come to you, Dr. Mona, just to ask you about, because you've answered some of this on the chat already, but if we could just ask you about, you know, the 3 different types of vaccines, which ones should people take? You know, are they all safe? Another question is, do they work for over 65-year-olds? I think that's something about the AstraZeneca specifically vaccine. So if you could just sort of answer those questions, please. Thank you.
So for us, we were waiting for these COVID vaccines to come through. And the first one which came through just happened to be Pfizer. Now, the Pfizer one, it needs to be kept at -70 degrees. So you can tell straight away you can't get it to the people. You need people to get to the vaccine. So when the Oxford AstraZeneca vaccine came along, we were really delighted, because that's a vaccine that can be kept in a fridge. That's a vaccine you can get right across Africa and Asia. That's the vaccine you can get to care home residents there and to care staff. And you can take that vaccine to the people. So that's the only difference for us from public health. That's the only difference. We were waiting for an Oxford AstraZeneca while we also had Pfizer. And now we have Moderna, we have a couple of other vaccines that are coming in as well. They're all safe, they're all effective. So the question is, which one do I take? You take the first one that's offered. The first one, you put your arm out, because that will protect you. If you delay, then you are not protected for 1 day longer, and you just don't want that to happen. We're choosing the people who are really most vulnerable, our top priority to get the vaccine. So you've been highly selected because you are vulnerable. If you're over 65, you're vulnerable. If you're over 80, you're vulnerable. So you take the vaccine that gets to you. We have care home residents who are over 80. We've got them, the Oxford AstraZeneca, because that's the one that could get to them. We have other individuals who are younger, Pfizer, Oxford AstraZeneca, Moderna, whichever one you get, because this vaccine supply is really, really important. There's huge logistics involved to keep that supply safe and to get it to people where it's most needed. So the last thing we want is either vaccine hesitancy or people who think that they can choose. Actually, they're all safe and they're all effective. And so that's probably the key message I want to give. Thank you.
Thank you so much for that. And I think there was another question related to, but I'll come back to that basically. So there's been lots of questions about fertility. So I don't know who from the panel would like to answer those. But so there's a question about somebody's planning for a baby next year and they're wondering if the vaccine would impact on their health or pregnancy. There's other questions that we've had about whether or not it would impact fertility. So if I could just open that up to the panel.
I'm happy to start the discussion. So as I mentioned, we have guidance from the Royal College of Obstetrics and Gynecology, which is the leading body in all things related to women. So they are the people that organise care for pregnant women for all other things. So the recommendation for them is that you need to consider your risk if you are pregnant and wanting the vaccine. So for example, someone like me, like as a health worker, you know, my risk of getting COVID is higher than the regular population. So if I am going to be pregnant, then I'm also advised to get the vaccine because I am also very, very likely to become very sick if I get the COVID infection. That is the same across the board. So if you are a pregnant woman with underlying health conditions, if you have you know, if you're working in the healthcare, there are lots of little caveats to that. So the best discussion is that if you are pregnant and you're considering vaccination, is phone up your GP. As Sara said, they are working incredibly hard at the moment and would be happy to have that discussion with you. Now, in terms of fertility, I've already discussed it. There's no evidence that it affects fertility. In fact, several women have got pregnant, both in all of the trials, actually. So the data emerging shows that there have been pregnancies in all of the phases of the trial, and actually even now we have observational data that people that are getting vaccinated are still getting pregnant. And the advice from the college is that if you are trying to conceive, you should, and you are told to get the vaccine, that is your priority. Your priority should be vaccination.
Yeah, can I add in a bit about breastfeeding, if that's okay?
Yeah, please.
So breastfeeding women, if they're high risk, should get the vaccine and also continue with the breastfeeding. Don't stop the breastfeeding because you've had the vaccine. So just to include that. And if I could just mention one thing, in terms of contraceptive pills, there is this idea that, so the combined oral contraceptive pill, the pill that often women were taking for 3 weeks, then having 1 week off for a period, then 3 weeks, often now people take it back to back, that can make your blood a little bit stickier. And the thought process that with COVID as well, one of its complications is making the blood a bit stickier and causing blood clots. So if you were to start the contraceptive pill during the pandemic, your GP might advise you, and I've been doing that today, to try the mini pill instead, which doesn't increase the stickiness of the blood. If you're already on a pill and you're established, you continue what you're on. But if you're starting, you might want to consider the mini pill, which has no estrogen in compared to the combined oral contraceptive pill.
Thank you. Thanks so much for those answers. So there's been some other questions about the vaccine. Again, there's lots of questions actually about the vaccine. So I'll ask the question and then whoever wants to, from the panelists wants to take it up. So the question is, how can they be so sure there will be no long-term side effects of the vaccine? There's also a question about, has the vaccine been tested on people with severe lung conditions and what results did they get? And were all the vaccines tested on humans? And I think there was a final question, how long were the tests carried out for the vaccine to check for side effects? And how serious are the long-term side effects? So I've kind of bunched them all together because I think they kind of all relate to basically the safety of the vaccine and side effects and the testing of it. So I don't know who from the panel would like to answer those.
So I'll just make a start really, and then my colleagues may be able to explain a little bit more about the clinical trials. But just looking at the safety, and also if we remember the question I was asked about someone who's over 65, people who are vulnerable are the ones who we're reaching out, people with heart disease, with lung problems. You know, those are the ones which the virus will definitely have a severe consequence. So those are the ones where we're saying the vaccine will protect you. That definitely the vaccine offers protection from the virus, and the way it does it is you mount an antibody response, and so you remember the virus rather than the vaccine staying in your body at all. So the vaccine gets eliminated from your body just within a few days, but you've started already to recognize it and start to mount an immune response. So next time the real thing comes, you recognize it, and the whole immune response then kicks in. So that's how the vaccines are safe. They're not introducing any, virus in its kind of like dangerous way at all. It's just a little bit of the virus, a little bit of its buttons and a little bit of its coat, just so that you remember. And that's probably some of the questions we get asked about these new variants as well. So the way I explain that lipid layer where the virus has a coat on it. So the coat and the virus, it's still the virus. It can change its buttons, it can change the color of its coat, but it's still the same virus, and you'll remember it. So even if it's a new virus, if it's a new variant, the vaccine, as far as we can tell, still covers you for that, and it protects you from all these new different, slightly different variants of the virus. Thank you.
Yeah, I mean, in terms of trials, so we've had animal trials, and as we were talking about earlier, that obviously children and pregnant women were not included in the trials, but pregnant animals were included in the trials. In terms of the Pfizer vaccine, 40,000 were involved in the trial, which is quite a large number, and 11,000 for the AstraZeneca Oxford vaccine. So those are the kind of numbers that we're talking about. And they're saying that 2 to 3 months follow-up, no serious side effects at all. They're saying that any serious side effect in the data is the risk is 1 in a million that you would suffer a serious side effect to the vaccination. So I think if we look at statistics, I think it's a case of balancing, isn't it? And we do this day in, day out. What do we take, or what do we do? And what benefit and what risk does it cause us? We make these kind of utilitarian judgments all the time. We do that for ourselves. We do that for our families, for our loved ones, in our neighborhoods. We do that as doctors. Nothing has no risk. If I'm giving aspirin to a patient, there is a risk. I will sit and I will explain what the risk of aspirin is. Taking paracetamol doesn't come without risk. Everything has a risk, and in everything that we do, we balance the risk and the benefit. So if we're looking at the statistics here, we're saying 3 deaths a minute from COVID, and the risk of a serious side effect of the vaccination is 1 in a million. How do we balance those kind of statistics? And I think that's what we need to be doing really in our communities, talking about the risk benefit. And in there is quite a lot of theology as well. I mean, I know that quite a few people in the audience are Muslims, so we are encouraged to think like that as Muslims, to look at benefit and risk and weigh the benefit and risk and go with where there's more benefit and avoid where there's more risk. So I think those figures are very, very helpful.
Just to reiterate what you've said, Sara, so I'm going to talk about the 2 vaccines separately, because this is work that we've done with BEMA intensely. So coming on to the Pfizer vaccination. So as Sara said, so the human trials have happened in all of the vaccines. You can't give something to humans without there being a human trial. As Shagufta said, it has to go through several processes. So with the Pfizer vaccine, we roughly recruited 42,000 people globally, and most of them had subgroups of things that had stable chronic diseases such as hepatitis, diabetes, cancer. Some of them had COPD and other lung diseases, but none of them had serious or, for example, unstable conditions. So you have to be pretty stable and healthy to enter in the vaccination groups. Now, with the Pfizer vaccine, half of that group received a placebo and the other half received the vaccination. And I think it's really important to iterate that of the people that received the placebo, 162 people fell ill with COVID-19, of which I think we had just over 10% deaths and just under, sorry, not 10% deaths, 10% severe disease, and the rest had mild to moderate. And in comparison, only 8 in the vaccine group got COVID. So that's where that efficacy figure of around 90% comes out from. Now, in terms of the AstraZeneca vaccine, we had 11,000 participants. And again, it was very, very similar. None of the vaccines have included severe side effects, such as death. So no one has died in any of those trial groups. Similar participants were included, so from Black and ethnic minorities, although not as much. And the reason for that is that generally Black and ethnic minorities are less likely to volunteer themselves for research purposes, and that's across the board with a lot of healthcare conditions. So it's not that they weren't selective, it's just people have to come forward. I just wanted to reiterate that point. And again, the AstraZeneca was a double-blinded trial. So what that means is that the doctors that conducted it and the researchers don't know who's going in what group, because that eliminates bias. So like Sara said, I think it's really important that we balance the risk of giving something with its side effects. Now, I, as a paediatrician, talk about vaccines for a living. And one of the things I talk about, for example, when people tell me we don't know the long-term side effects, is the chickenpox vaccine, right? So the chickenpox vaccine is currently not in the UK schedule, but is worldwide. But we don't have long-term data on it. We have roughly 10 to 15 years of data. And if you look historically at the way vaccines and the way disease happens, there has to be an element of risk. If people 50 years ago didn't take the polio vaccine because they didn't know the long-term side effects, we would still have polio in many parts of the world. It's the same with things like measles. Now, if you look at measles, the UK lost its measles status a few years ago because of the anti-vax movement and because of the ridiculous misinformation regarding the measles vaccine and MMR and its relation to all sorts of stuff. But vaccines do work. And we know that they're safe. We know that from historical data. So if you want to, look at the data, it's readily available. We're not hiding it. We're not sitting in it. I don't make a profit from it. Sara doesn't earn millions from Pfizer. Shagufta may have, but that's because she worked for them, not because of conspiracy theories. So if you can vaccinate yourselves, I promise you, none of us would be sitting here, as Muslims, as people of faith, encouraging you to do something that we didn't so wholeheartedly believe in.
Thanks so much, Kiran, and thank you, Sara.
Do you mind have you got a minute for me to add? Or
yeah, sure, please go ahead. And if you might want to just address that, there's been quite a specific question as well about the vaccine and Bell's palsy. So I don't know if you can address it, or maybe somebody else can just address that specific question.
Right. Yes, Bell's palsy. Okay. It's interesting actually, because we hear about vaccine hesitancy on the one side, and I think that's where I would encourage our communities, our imams, our youth workers, our community workers to really, really speak to their relatives. And it's not about being patronizing at all. It's very real to have concerns. We all have concerns. My daughter is a 4th-year dental student and was offered the vaccine, and it felt so different when she was offered it compared to when I was offered it. I've had 3 children. I'm at the other end of my lifespan. My daughter's setting out in life. She's still gonna, hopefully settle down and have children. It felt like a completely different decision. And it hit me then that my doubts were playing up for her. She had her vaccine because she's dental, and that's oral cavity, which is high risk. But I know that my mind played different questions were coming in my mind for her, than for me, than for my father, than for my husband, because of her age. So I understand, and I think that we need to have these conversations, and people that the community trusts are the people that really need to be speaking and reaching out. Particularly people who may not be able to read the information in English or listen to videos or read reports that are in English. It's about getting information to people in the language that they understand through the trusted mediums, and we can all play a role in that. today, you know, so many of my patients were asking me to write letters to expedite their vaccines. They weren't in the category that they're deserving of the vaccine. So today was a 55-year-old gentleman with an irregular heart rate. And he was saying, you know, can you get my vaccine done? I want it. And he's not in the category because it's only got to 65 years old plus, and they're clinically extremely vulnerable right now. And we're moving on to the 16 to 64-year-olds. So it's going to take time. So it's that point that, you know, some people are so desperate to get the vaccine, and then there's some vaccine hesitancy. And it's a case of speaking to both sides, really. In terms of Bell's palsy, my understanding is there's a background. So we were seeing Bell's palsy before the pandemic, and sometimes you see unfortunate people who have repeated Bell's palsy. I've had Bell's palsy. It was from an experiment that we were doing in medical school. So I had a viral Bell's palsy. So there's a background level of Bell's palsy that occurs in the community, and the documentation, the research at the moment is that some did suffer from Bell's palsy during the trials, but the idea and the thought is that it was the background rate anyway that was affected. So if you have a population that's undergoing a vaccine trial, you'll still have a background rate of heart attacks, of chest infections, of strokes that are going to be occurring. So it's only if that background rate gets exceeded that you'll think, okay, did the vaccine cause this? So the Bell's palsy rate did not go up. It was considered to be the background rate. Bell's palsy is often a viral condition that affects a nerve. It's the nerve in your face that causes your eyebrow to lift, your eyelid to lift, your smile to be symmetrical. And so that can droop if you get a Bell's palsy, often reversible.
Yeah, just to say that actually the vaccines don't have the virus, which I think is a common misconception in the community, that we are giving you a live virus. So there is no live virus. So the Bell's palsy is not coming from the vaccination. It's often a result of your immune response. So you can even have it in secondary to like a cold sometimes. We don't know exactly who is more susceptible with stuff like this, but like Sara said, it is just the background rate. You know, nothing that we're worried about in the scientific community.
Yeah, can I just add that I have nothing to gain by promoting the vaccines personally, except for I have in the past worked for Pfizer. I know they are a very ethical company to work for, and they literally encourage their scientists to do the best they can for science. And I've also worked with the MHRA. I know how effective they are as a regulatory body, and they just don't leave any stone uncovered if they can. So that's why I wholeheartedly believe in the vaccines. And I've had the vaccines, and I'd encourage anybody to have the vaccines. My parents have had the vaccine, and yeah, like I said, I've had both jabs and I'm perfectly fine. Thank God. Alhamdulillah.
Shagufta, can I just ask you, we had a question, basically a very specific question about apparently the government website advises medical practitioners that AstraZeneca vaccine contained chimpanzee adenovirus, which was produced in a genetically modified human embryonic kidney cell. And I was just wondering if you could just maybe, you know, talk about that. You know, what does that mean? Because I know there's been some I guess from that information, then there's been some sort of, I guess, misinformation then that's then carried on when people kind of tell that's, you know, that information to another person, almost like Chinese whispers. So I was wondering if you, because I've, you know, had a doctor explain to me, you know, the origins of that and all of this kind of stuff, but maybe if you could just explain for our audience, please.
As far as I'm aware, that cell line was created about 50 years ago, and it's been used since then. So nothing new's been introduced. And originally, it originated from a chimpanzee or whatever. But yeah, that was 50 years ago. Kiran, I don't know if you want to add something.
Yeah, sure. I'm happy to add to that. So historically, all vaccines, most of them that we use in the UK come from 2 cell lines. So one of the controversial issues surrounding the cell lines is that they are fetal cells. So I want to make it really, really clear that no fetal cells are in any of our vaccines, and no human embryonic products are in any of our vaccines, including the coronavirus vaccines. Okay. Lots of people donate stuff for medical research research. So when people die, they may donate their kidney, their heart, their eyes, their lungs, or their entire body for medical research. So these initial cell lines are from the 1970s, where a pregnant woman that had a legal abortion for medical issues donated her cell lines for research. And we often use human cells to culture stuff before we take out what we've cultured and then produce medicine from it. So there's no human cells in the vaccine. Now, coming back to the chimpanzee in the AstraZeneca, so we use a chimpanzee adenovirus, which is the CHAD and that is used as a vector. Now, what that means is that it's simply a device that uses it to help our body recognize that spike protein so that we can build an immune response. We are not giving you chimpanzee data. That's not what we're doing. We're not giving you chimpanzee cells. Using vectors is very, very common. And the reason we use things like chimpanzee adenoviruses, it's because their DNA is very, very closely similarly to ours. So it helps our body build that immune response better. So again, like Shagufta said, these cell lines aren't new. We've been using this type of research and this methodology for vaccinations. We've been using it for example, for HIV medication. We use it a lot because it's the way we introduce a foreign substance into the body to help your body recognize, and often we need a vector, and that's essentially what that chimpanzee adenovirus is. It's just something that's carrying it in to our body to fight the immune response, but we're not giving you any genetically modified organisms, we're not giving you fetal cells, we're not giving you chimpanzee cells, or whatever animal cells you can think of.
Thank you. And if I could just come to both our doctors, Sara and Kiran, our medical practitioners, I mean, if there's questions about basically asthma or people who are taking medication for lung conditions, if you could just sort of clarify on that. Is it safe for those types of people to take the vaccine?
I would actually argue, I would encourage those type of people to take the vaccine. So asthma, things like lung fibrosis, sarcoidosis, COPD, your lungs aren't healthy. They are healthy, but they're not in the best condition. So when you have an underlying condition like that, and we know from the deaths and from the ONS reports that people with underlying conditions like asthma are more at risk of becoming very, very unwell, because your risk of hypoxia, so hypoxia is when the oxygen level drops, is significantly higher than the healthy lung population. So I would encourage those that have pre-existing conditions.
Yeah, I did want to add on to that, but before I did, sorry, I was in a conference where Dr. Mona also said something about the embryonic material. Dr. Mona, if you wanted to, and then I can come back about the chronic diseases.
Yeah, sure, go ahead.
Thank you. So the adenovirus that AstraZeneca uses is one that infects the chimpanzee. It's not one that is a chimpanzee cell in itself. And that's been inactivated. And it's just used to introduce the virus, the vaccine back into your body so that then you can start to fight it. And the cell lines for sort of the one that Kiran's just described is one that's being used, for example, for every season for the flu virus, for the flu vaccine, to be cultured and then taken out. So these cell lines are in use for many of the vaccines that we are currently using, and we are taking these vaccines in the same way as we take paracetamol, and we don't really question. So I think that's something that we have to be really clear about. Why is it that suddenly we're questioning what's in a vaccine when we don't really read properly what's in many of the medicines that are in our counters that we are taking each day? They are all equally safe. They've all been tested in exactly the same way. And it's just now, I think, one of the things that we must be wary of. Because of our concerns, we're worried that we will be disadvantaged by taking a vaccine because we're concerned. Actually, by not taking the vaccine, we are disadvantaging ourselves. We are creating a situation where our communities are now really vulnerable to a virus that is killing them and is actually having the most severe disadvantage, most severe consequences on our communities. So that's why we're urging you to take the vaccine. We know it's safe, we know it's effective, and we just really can't understand how we may be disadvantaging ourselves. Thanks, Sarah.
Yeah. I mean, I think we're in a real time nationally where there's just such an erosion of trust. And I think that is fundamentally, critically the issue, that there is an erosion of trust in government, in bodies, in so many ways. And that erosion of trust is affecting people. But if we think about it, actually the biggest inequality, apart from the inequality here where you see that so many people from the BAME community are being affected, actually internationally, we're going to see third world countries struggling to get hold. We have over-ordered, and there are going to be countries that are going to struggle to get even 3% of their population covered by the vaccine. So we are lucky. We are so lucky to have more than one vaccine available. We have staff rolling it out. I mean, on my phone, there are call outs every evening because there are some vaccines left. And doctors are saying who hasn't had their first one, because otherwise it's going to go. It's only got so many hours that once it's been diluted down that it'll last before it has to be binned. Who's not had their first vaccine, come and get it so it doesn't get binned. And people are just going out to get their vaccine. We are so very fortunate. So I think this erosion of trust is really what's manifesting here in communities, causing these small whispers to just gather momentum. In terms of the question about asthma and at risk, so there's two categories here. If you look at the order in which people will be called, you have your group 4, which are the clinically extremely vulnerable. There'll be people that you know who are shielding right from the beginning, and they would have received a letter centrally saying that you should be shielding. That will include certain types of people, including those who've had organ transport, those who have organ transplants, those who are having active chemotherapy or radiotherapy, and so on. You then have your group 6, and these are the people that are at risk. And the at-risk groups include people like those with chronic bronchitis, those with asthma, those with certain heart conditions, and so on. So whereas your mind would think they're at risk, so they shouldn't get the vaccine, it's the exact opposite. They're at risk. They are being prioritized for the vaccine. So they're being prioritized above a 55-year-old. They're being prioritized for the vaccine because should they get unwell with the virus, they will suffer more severe reactions and severe consequences. Now, when you look at the BAME community, when you look at the levels of diabetes, blood pressure, heart conditions, obesity, and so on and so on and so on, family histories and so on, you will see that our communities carry this risk. They carry it because they have so many pre-morbid conditions, so many other medical conditions, which means that when they get the call, they should take it because they're at risk, they will be more likely to lose their lives or need a ventilator should they get COVID. Therefore, you take the vaccine because, as Dr. Kiran said, it's not an active virus that you're receiving. You are receiving the priming of your system to fight it should you face it.
Thank you. And now I'll just sort of ask the final questions now, because I know that it's coming up to 9 o'clock. So we've had questions about, will the existing vaccines work for new variants? Will they mix up doses, I think is a question. And will we need to take a vaccine every year, similar to how we do with how some people do with the flu, basically? I'm opening up to anybody who would like to answer it.
So I'll come in a bit around the variants, because there have been hundreds from March, really. And that's the way the vaccine survives in all different environments around the world. It just tries to make sure that it's able to replicate and able to infect us as the human host. And so far, we pick it up with the same tests and the vaccine still protects. Now, how long does immunity last? And will the virus keep changing, that we need to change the vaccine? Well, we're used to doing that with the flu vaccine, because that's what happens every year. We detect which circulating virus, what does it look like, how can we protect against it, and it's manufactured at the end of every year. So worst case scenario, if we are like the flu vaccine, then the coronavirus vaccine can keep, being updated and changed each year if we need it. But if we're lucky, immunity may last a lot longer. So we're just here to see. Thank you.
Thank you so much. I just want to say before I hand over to Shameen, a huge, huge thank you to our panelists. Thank you so much for taking out time to speak to us this evening. Kiran, you've got your hand up. Do you want to say something?
Just because I've noticed there were 2 questions about when will children
Sure.
be eligible for vaccines, and
Go ahead.
sorry, I feel like the child voice is always lost in public health. So children fall under phase 4 of the vaccination, and you are only eligible for it if you're 16 and over, and currently if you have an underlying risk. So for those children that are that are shielding or have health care issues, your specialist teams should be contacting you nearer to the time of that phase 4 vaccination rollout as to when you will be eligible for it. Under 16s are not eligible for it at the moment. Oh, someone says, why can we not see you? I'm sure can you see me? Oh, okay, yeah. So at the moment, under 16s are not eligible for it. So if you're 16 for the Pfizer and 18 for the AstraZeneca, we will start rolling it out in phase 4 of the trials. So please contact your specialist teams. So I know I'm talking to a very small population, but if you have a child, they usually have a pediatric team, whether that's a lung team, a heart team. They should be giving you letters in the next few weeks and months about who is eligible. But remember what I said about that surge we are expecting in children becoming very sick. So if you are offered a vaccine, please take it, because you will also keep the little ones safe.
Thank you so much. And I'm just going to read out a comment from Roxana, because I think it really just does sum up what I want to say. And she says, mashallah, a wonderful session, a very positive session with amazingly wonderful and professional Muslim women. I'm so proud of you all and the excellent work that you are all doing. And I think, that I think sums up how we all feel. So thank you so much to all of you. And I know you all are working on the front line, or in some shape or form you've got your you're out there basically working in the thick of it. So thank you so much. I'm now gonna hand over to Shameen, who's gonna sort of close off the session. Thank you so much.
Thank you, Akila. Thank you so much to all the panelists and everybody who's attended. Just before we close, I just wanted to ask if any of the panelists, any of the doctors have any final thoughts or reflections before we close that they just want to add, or something that they've missed and they just want to add, if you do, or any reflections. No? Yes, Kiran?
So I am going to share something really personal with you guys. So I worked in ITU. I'm a pediatrician. I haven't done adult care in almost 10 years. So I qualified I started training as a pediatrician in 2013. I qualified as a doctor in 2011. So the first time I went into adult medicine was in ITU last year. And it is single-handedly the worst thing I have ever done in my career. And I can't even begin to tell you how devastating it is to have to resuscitate people that weeks ago you were walking down the corridor with, that you were teaching with, that you were asking for advice. In that 2.5 month period, I lost several nursing staff that I knew from when I was a medical student. One of our really excellent teaching surgeons passed away. He was a lovely Bengali gentleman. I work in the East End of London, and so our hospital was really badly hit because of the poverty around where we live. And I lost one of what I would consider mentors who taught me how to be a doctor. He taught me everything I know. He was an excellent nurse. And to lose people like that, and then have to listen to these conspiracy theories, and then have to listen that COVID isn't real. If I could honestly give you a glimpse of what goes on in ITU, to tell families over their phones that they can't come and say goodbye, that their so-and-so has passed away, that their uncle, their aunt, their brother. I've seen children, well, not children, young adults. When I was in ITU, the youngest person I looked after with coronavirus was 17. No underlying health conditions. So my final thing is, it is very, very real. And we all need to do our part. I have a small child at home, so I'm a mum of two, and my eldest falls in a very, very vulnerable risk. And so if people like me and people like Sara and people like Dr. Muna are going into work and putting our lives on the line when we have vulnerable people in the house, we are asking you as a community just to do the basics. And the basics are: put your mask on, keep away from people and don't mix, please, and wash those hands as much as you can before you eat, after the toilet. Wash them, please. And that's all I wanted to say.
Thank you, Dr. Kiran. Dr. Muna, you want to say something?
So one of the things we've been trying to do is bring down the rates of transmission. And how can we do that? We can do that by halving the numbers of interactions we have as individuals. So think before you meet up with other people you don't live with. If you can halve your interactions and everyone around you does the same, we can halve the rate of transmissions and we can come out of lockdown. One of the things I want people to do is use their voice, because people don't want to listen to the experts. And I'm really grateful to the audience who came in here and actually are listening to us. Please use your voice. Your family, your networks will listen to you. Don't just share this video, because actually people may forget it, but it's your words that will make a difference to your close family and your loved ones. So use your voice. And I think she speaks, we hear. I think we all should speak out and we should all listen. Thank you.
Thank you, Dr. Muna. Dr. Sara, you wanted to say something?
Yeah, just reiterating the bit about how we all have a responsibility really to challenge misconceptions. Both Dr. Kiran and Dr. Muna have said this, that we all carry that, and actually your circles of influence are probably much greater than someone like mine who's seen as already buying into the system in some kind of crazy, strange way. So actually, please use your influence to challenge misconceptions. I think the other thing is, you know, as Dr. Kiran said, is that we all have a responsibility. There are people who are serving us on the front lines who are losing their lives, you know, day by day. It's just heartbreaking to see. You know, you see at the beginning, we saw doctors from the BAME community, nurses, healthcare workers, people in care homes losing their lives who had no underlying condition. So fit, healthy people, you know, so that's when it really shakes you. So we all carry the responsibility not to be transmitting this virus. And I think just from a GP perspective, one of the things is we don't all have to be coping really, really well. You know, we don't have to have a social media that shows that we're doing everything and running 5K. It's okay to be struggling through all this. And I think it's also really important to recognize the importance of mental health and all the other aspects of our health, and to use the services that are available. So get in touch with your GP if you're suffering and struggling. Don't think that we all have to put a brave face on at this very difficult time.
Thank you, Dr. Sara. Was there anything you wanted to add, Dr. Shagufta, to that? Oh, you're on mute. Just need to unmute yourself.
Just a few general points. It's a difficult time for everybody, to be honest, and you know, it's a good time if you live by yourself to connect with others, and if you live with others, to take time out for yourself, and you know, look after your eating habits. Try and eat healthy, and have the odd junk food as well, just to alleviate your mood. You know, it's just a question of taking one day at a time and being looking after yourself and others as much as you can, and you look after others by hands, face, space. Thank you.
Thank you, Dr. Shagufta. I think it's a real tragedy that the biggest, we have the largest vaccine hesitancy in our communities when we're the ones who are affected the most. So thank you to all the doctors for trying to alleviate some of those valid skepticisms and things that we've all heard, and, you know, just alleviating some of those fears. And, you know, just remembering that the first victims of COVID, the first NHS workers were Muslim. They were from the BAME community. So it's very real. And you guys have done an excellent job helping and on the front line every day. So thank you so much to all of you. And thank you to all the panelists and your questions. I hope that's, I can speak for everyone when I say that that's really helped, and I've got lots of information. I thought I knew quite a lot about COVID-19, the vaccine, but turned out I didn't. So that's really helpful. As far as She Speaks We Hear is concerned, inshallah, God willing, we will be putting on more events if people want us to, with regards to COVID. And if you want to follow us, we are on Instagram and Twitter as She Speaks We Hear. So please do give us a follow, then you can be updated with anything that we are organizing. I hope any other questions, you guys can follow. I'm not sure about everybody's Instagram or social media, but if any of the panelists want to give theirs, I know Kiran's is at the Munching Medic. If any of the other panelists want to put their social media on, please, you can add it to the chat. But I'll let everybody go because it's now past 9 o'clock. So thanks again for your time. We really appreciate it, and keep doing what you're doing.
Our pleasure. Thank you for having us. Take care, everyone. Assalamu alaikum.
Walaikum assalam.
Thank you so much. Take care.
Bye-bye, everyone. Bye-bye.